Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Hello everyone, my name is Dr. Coviello. I'm excited to be here today to discuss our recently published manuscript in the Facial Plastic Surgery and Aesthetic Medicine Journal, examining open surgical treatment of subcondylar fractures through the retromandibular infraparotid approach. I'm joined today with our senior author, Dr. Sunthosh Sivam, to discuss some of the key findings related to our paper. So Dr. Sivam, what was the motivation behind this project? Why look at a new surgical approach?
Thanks, Caitlin, for having me. As you know, subcondylar fractures are very common, and despite us seeing a lot of them, the management's often debated. Overall, our main goal in treating a patient with subcondylar fractures is to make sure that their native occlusion is restored, that the joint is functioning well, and we want to achieve both of those things in a way that minimizes complications. So those that favor closed approaches generally feel that the risk with open treatments, may not warrant what we are able to achieve just with closed treatments. On the other hand, when a surgeon may favor an open treatment, they may feel that they are getting those bones to be in better alignment rather than with a closed approach where we, by definition, accept a malunion at best. And so there can be some long-term sequelae. So we wanted to look into open approaches in a little bit more detail. There are, of course, a variety of open approaches that have been described, including retromandibular, submandibular, transoral, and endoscopic assisted approaches. Retromandibular approaches specifically can be further classified into retroparotid, transparotid, or transmesenteric anteroparotid approaches. With many of these, the feared complication is injury to the facial nerve, which has been cited to be anywhere from 14 to about 27%. So we believe an ideal surgical approach would allow for excellent functional outcomes without adding significant risk to the facial nerve. And so in our approach, we describe a specific technique that kind of borrows from different techniques that surgeons may have tried previously. And when we put it all together, we felt that the best description would be a retromandibular infraparotid approach. And with our focus of our study and the looking at our outcomes would be looking for any facial nerve deficits following the procedure.
And with this new surgical approach, would you mind just describing it for the listeners in a little more detail?
Sure. So we start with a smaller modified Blair approach. And so we make our skin incision and then sharply dissect through the platysma. We do raise small superior and inferior subplatysmal flaps. From there, we identify the external jugular vein as well as the greater auricular nerve. And we try to preserve both in most of our approaches. From there, we expose the sternocleidomastoid muscle as well as the posterior belly of the digastric. And we elevate the tail of the parotid from the SCM, which is really key in being able to mobilize the parenchyma of the parotid superiorly. By maintaining the surrounding parotid parenchyma around the facial nerve, we find that it can tolerate traction better, and we do have to do a fair amount of superior retraction to get up to the subcondylar area. So by elevating the tail of the parotid, mobilizing it from the SCM, and retracting that entire parenchyma, we disrupt the parotid fascia minimally and keep the facial nerve protected. Once the parotid is mobilized, we find ourselves looking at the mandibular angle and ramus. Sometimes getting down to the angle of the mandible, we can assist ourselves by using a bite block or mouth prop intraorally, which brings the angle of the mandible back towards our dissection. Also helpful in getting better superior exposure is grasping the posterior body of the mandible through our approach with a coker clamp and putting inferior traction on the bone, and that brings everything into visualization. And we can watch our reduction as well as facilitates keeping things in reduction. From there, we can use our fixation of choice. We most commonly use a 1.25 millimeter 4-hole compression plate. We pre-drill all of our holes, and we typically will use 6 millimeter screws in these plates. Most of the time, I recommend starting with the superior segment and putting our first screw there, and that way we can utilize the plate to hold the reduction or hold the fracture in reduction, and then complete fixating that plate. We then, of course, wash the wound bed out and achieve hemostasis and close in a standard fashion.
Thanks for describing the technique. So in your study, who was your study population, and how did your team carry out the study?
So we performed a retrospective review from our level 1 trauma center, and this included all adult patients with new subcondylar fractures from 2019 to 2022. And we looked specifically at the patients that underwent open surgical treatment using the retromandibular infraparotid approach within our own department. We did exclude patients who had prior mandible fractures, abnormal preoperative facial nerve exam, or insufficient data within the electronic medical record. We looked at data including demographic information, the fracture characteristics including pre- and postoperative CT images, facial nerve function using the House-Brackman scale, as well as any relevant postoperative complications.
And then what would you say were the main results of this study?
So ultimately, we had 26 patients that met inclusion criteria. Most of them were male with an average age of 40 years, but our patients range from 21 to 71 years. Happened to be that most of these fractures are on the right side, as well as displaced. The average displacement on the CT scan was 7.5 millimeters. Ultimately, there was one postoperative infection that was treated with antibiotics and resolved. Otherwise, there were no substantial complications. Notably, no sialocele or salivary fistulas were seen. On our first postoperative exam, 4 of the patients, or 15% of our patient population, did have lower lip weakness. This resolved in 2 of those 4 patients in their most recent follow-up, and the other 2 were lost to follow-up after their first post-op visit. So on this patient population, our average follow-up was at about 25 days.
And based on those results, what are some of the key findings that you would like the readers and listeners to take away from this study?
Our primary outcome, which was facial nerve function following this specific surgical approach, is pretty comparable to what's been previously reported in the literature as it relates to isolated lower lip depression weakness. Interestingly, a recent in vivo study by Kaufman, Goldberg et al. Found that the cervical branch of the facial nerve more commonly innervates the depressor labii inferioris rather than the traditionally accepted marginal mandibular branch. And I think we see this in our data. This transient lower lip weakness may be related to retraction itself, but this recent study also explains why there's higher rates of lower lip depression weakness when we do retromandibular approaches in general. We do think that additional care should be given to the cervical branch of the facial nerve as a result of our study and this recently published anatomic study. An additional finding that was interesting was our lack of sialocele or salivary fistula formation. A prior systematic review looking at management of subcondylar fractures found a rate of sialocele and salivary fistula formation to be anywhere from 5 to 8%. Our technique, as discussed previously, minimally disrupts the parotid fascia, mobilizes the entirety of the parotid parenchyma so that things are not disrupted, which may explain the lower rate of parotid complications in our cohort. In conclusion, open repair of the subcondylar fracture through this retromandibular infraparotid approach provides adequate access to properly reduce a fracture, plate the fracture with relatively low complication rates, specifically isolated lower lip depression weakness.
That's great. Thank you, Dr. Sivam. Has this research study opened up any ideas for future directions or projects that you'd like to look at it?
Yes, definitely. Our main goal is understanding outcomes in the acute postoperative setting, but we did ultimately have a short follow-up period which limited our assessment for long-term complications. In the future, I think we want to pursue a prospective study so that we can better understand long-term outcomes with our surgical approach.
Awesome. Well, thank you for taking the time to discuss our findings. We hope the audience enjoyed our discussion and gained some useful information related to the management of subcondylar fractures that they can apply in their clinical practice. If anyone has any questions or comments regarding our manuscript, please feel free to reach out to us at sunthosh.sivam@bcm.edu.
We'd like to thank the authors for their commentary and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.